Hello, and welcome to Why Do We Do That? A psychology podcast that deconstructs human behavior from the perspectives of social scientists, psychologists, and others that use applied psychology in their work. I'm your host, Dr. Ryan Moyer. In this episode, I sat down with clinical psychologist Dr. John Abramowitz to talk about obsessive-compulsive disorder. John earned his PhD in clinical psychology from the University of Memphis. He has over 25 years of experience and is internationally recognized as a leading authority on the treatment and study of OCD and other disorders related to anxiety. His contributions to the field of OCD, anxiety disorders, and clinical psychology have been recognized by awards from the National Institute of Mental Health, American Psychological Association, International OCD Foundation, and the Mayo Clinic Department of Psychiatry and Psychology. He is a fellow and past president of the Association for Behavioral and Cognitive Therapies, founding editor of the Journal of Obsessive-Compulsive and Related Disorders, and a member of the editorial boards of several other scientific journals. John has also authored numerous books, including Getting Over OCD, a 10-step workbook for taking back your life, and The Family Guide to Getting Over OCD, Reclaim Your Life and Help Your Loved One. He is currently a professor of psychology and neuroscience at the University of North Carolina at Chapel Hill, where he also maintains a private practice. One key takeaway I had after chatting with John is that it is important to draw distinctions between OCD and everyday ritualistic behavior. Lots of us have observed someone's behavior, or perhaps our own, and thought we have a touch of OCD. I think we need to avoid this tendency as much as possible, because when we blur the line between being quirky and having a disorder, it makes it difficult to determine when someone should reach out for help. Now, it's also probably a good idea to monitor our rituals as to gain some insight into how we are coping with the world we live in. But the fact is that most people have obsessive thoughts sometimes. We should give ourselves some grace when we notice these patterns of behavior, and we shouldn't jump to clinical labels without first talking to a professional. Another insight I had after speaking with John was that the key to treating OCD echoes the sentiment of many mental health interventions, which is that exposure to discomfort is the gateway to rewiring the nervous system. People with OCD have strong mental and physical responses when their behavioral patterns are interrupted. But exposure to alternative thoughts and behaviors can lessen the degree of those learned responses and create healthier patterns of behavior. If you have had personal struggles related to obsessive thoughts and anxiety, with or without an OCD diagnosis, I hope that this discussion on OCD provides some insight into how obsessive thoughts operate in our minds and how they can be effectively managed. Enjoy. Okay, today I am joined by Dr. Jonathan Abramowitz. Thank you so much for being with me today.
You bet, Ryan. Thanks for having me.
We are here today to talk about OCD, which stands for Obsessive-Compulsive Disorder. Jonathan is a researcher and a clinician who specializes in OCD. And why don't we start by just giving a broad definition of OCD and the typical features of individuals diagnosed with OCD?
Sure. OCD is an anxiety-related problem, disorder, diagnosis that involves two main symptoms. As the name of the disorder sounds, you have obsessions and you have compulsions. And obsessions are unwanted, intrusive thoughts or ideas or images, just kind of private experiences that people have in their mind that are unwanted, and the person feels like, I don't want to be thinking this, and they experience the thoughts as distressing, intrusive. And compulsions are the efforts that people make to try to dismiss or reassure themselves about the thoughts. They try to get rid of the thoughts. They try to control the distress associated with them. Classic examples are things like obsessions about, what if I open the door with my hands and there are germs on the doorknob, right? And now my hands are dirty and I'm going to get sick, right? That's a classic example of an obsessional thought. And then the person goes and they wash their hands and then they're like, oh, I feel relieved. I got rid of the germs. Now I can go on. And that'd be a classic example of a compulsion. But you can have obsessions about lots of different things. You can have obsessions about responsibility for harm. What if I hit someone with my car and didn't realize it? You can have obsessions about like immorality. What if I had a thought, I'm married, what if I had a thought about, hooking up with someone, someone else? And then the person might have a compulsion where they have to pray repeatedly, or they have to check, or they have to get reassurance that I'm not a bad person. So many different areas really that people can have obsessions and compulsions about. But I guess, the main thing, Ryan, is that obsessional thoughts provoke distress. Compulsive rituals are things that the person does to try to control the distress and the thoughts. And over time, this just develops into a vicious cycle where they're doing more and more obsessing and compulsing. So it gets in the person's way.
I definitely want to dive into a little bit more of those specific manifestations or subtypes. But first, I wanted to talk to you about the trait in general. I've talked to a lot of clinicians lately, and there seems to be this common theme with many psychiatric diagnoses, which is you have a version of the disorder, the symptoms of the disorder exist in just about everyone in a much lesser degree. So we might call those traits.
Yeah.
So people might be suffering from social anxiety, but social anxiety isn't a disorder unless those, everyone has anxious thoughts, but for people with social anxiety, it's extremely distressing. For ADHD, everyone experiences distraction, but in order to be diagnosed with ADHD, it has to be much, much more intense and disruptive.
Yeah.
Is OCD characterized similarly in the sense that there are obsessive traits? And if that is the case, what are the key differences between the diagnosis and just being a person with these types of traits?
Yeah, that's a great question. So OCD, like everyone has a little bit of OCD. Although what I should say though is that very often people mistake the clinical version of OCD for kind of some of these traits, like, I like everything organized, or I like to clean my house, or things like that. Most of the time that is not OCD or even OCD traits. It's just kind of people having their own little, ways that they do things. But we all have unwanted thoughts. Everybody has thoughts that go against their values or who they are. So we all know to some extent a little bit what it's like to have an obsession. It's just that we don't call it an obsessional thought until it takes up a substantial amount of time, causes interference in functioning. So I'm avoiding lots of things. I'm avoiding watching, any show on TV that has anything to do with violence, because I don't want to have any violent thoughts, right? Because then I'll get thoughts about what if I harm someone that I love, right? So then, when the person's thinking about it a lot and all, it causes great distress. So that's when we call it a clinical obsession. Same thing with compulsive rituals. I mean, we all check stuff. We all sometimes, wash our hands a little bit more because we get the idea that maybe we're feeling contaminated. We all arrange things sometimes. And for the most part, it doesn't cause any problems when it gets in the way of functioning. So I'm stuck because I'm checking for hours at a time, or washing over and over again. That's when we start to call it a clinical obsession.
All right.
Yeah.
I was looking over some of the subtypes. You'd mentioned contamination is one of the most commonly occurring. And you mentioned fear of harm. Could you dive into a few of maybe I hate to use the term favorite subtypes of OCD, but just to describe what is typically seen in the population.
Sure. So our research group has actually looked at this extensively. Like, how do we group these all sorts of different types of obsessions and compulsions? How do we group them together? And it turns out that there are four kind of broad, I guess, types of OCD symptoms. As you mentioned, the most common is contamination. So obsessional thoughts about germs. It could be about, I'm going to get sick, or it could be just disgusting. We know that some people have a moral or mental contamination where they feel like they've had an unwanted thought and they feel like they're just kind of their mind is contaminated. So obsessional thoughts like that. And they often go with decontamination rituals. So washing and cleaning and avoidance of things that might be, germy or dirty. So that's the contamination, kind of domain, I guess, of symptoms. Then we see another type that is about responsibility for harm or mistakes. What if like I mentioned before, what if I hit someone with my car? What if I said a terrible racial slur to someone? And I offended them? What if I did my paperwork incorrectly? So mistakes, what if I'm responsible for something terrible happening? And that often goes along with checking, reassurance seeking rituals to make sure that everything's okay. So we see folks, here at I work at a university, we see folks who go, they send an email to their professor, right, students. And then they're going back in and they're rereading their sent emails. And let me make sure that I didn't say anything inappropriate, reading it over and over and over again for, just kind of reducing that distress, that obsessional thought about what if I made a terrible mistake and offended my professor who could give me a bad grade or something like that. Mm-hmm. So that's the responsibility for harm and mistakes kind of domain. Then we see another domain that has to do with order, symmetry. So sometimes these folks are concerned that if I don't have everything in order and symmetrical and lined up perfectly, something bad is going to happen. I have to line up the pictures or the books just right. Otherwise, magically, someone I love is going to have an accident or get hurt.
Is this include the counting?
So sometimes people have to count the right way. Exactly. That would be the ritual that goes with that, right? I have to count. I have to have things in order and arrange them just right. Yeah. Sometimes it's just about like, it just doesn't feel right if I don't have the right number on the speedometer when I park the car, or if I don't have the pictures hung just right, or other sorts of things that could be, balanced or even or stuff like that. So that's kind of the symmetry and order domain. And then we have the domain of just kind of intrusive, unacceptable, taboo kinds of thoughts that, again, we all have from time to time. They could have to do with morality, sex, religion, blasphemy, violence. What if I started attacking my family in their sleep or something like that? Things that the person doesn't want to do, and they're not going to do them if they have OCD, but these are terrible thoughts, and the thoughts get stuck in the person's head. And the compulsion that goes with that could be a number of different types of compulsions. Often it's reassurance seeking. Am I a bad person? It could be praying. It could be checking. It could be mental rituals where they're trying to undo the thought or dismiss the thought or suppress the thought. And unfortunately, all of those strategies, they might help in the short term to relieve the distress, but they only make the person have more obsessions.
Mm-hmm. So I've watched my fair share of My Strange Addiction, which does feature some of these examples. And it seems as though that trauma or an event is often associated with these types of diagnoses, but I'm sure it's not that simple. I'm sure it's not the case that there's always an origin story that adds up. But I am curious, if someone, for example, in their adolescence, they leave the door unlocked once, and that's the day someone breaks in, and that triggers this sort of obsessive compulsive cycle with safety. Could you talk a little bit about what we know or what's true in terms of how events or trauma relates to the likelihood of these behaviors?
Yeah. So like you said, I mean, the causes of OCD and any of these psychiatric disorders are really complicated. And it would be impossible to go back and say, is there one single event? That said, there are people who say, like you pointed out, that yeah, I had this experience, traumatic experience. And after that, I became worried and obsessed, and I started doing compulsions and all of that. And who's to say if that hadn't happened, the person might not have developed OCD or not. The thing is that those kinds of things happen to everyone to some extent or another. We all get sick sometimes, and we all make mistakes sometimes, and most people don't develop OCD from that. And
Right.
so you would think that even though a traumatic experience could trigger the symptoms, the onset of the symptoms, there are probably other factors. Like, how come that doesn't happen to everyone who leaves the door unlocked and someone breaks it? Because that does happen,
Right.
unfortunately, fairly routinely. I
So
should say,
that, yeah, so that makes me wonder as a follow-up,
yeah,
right? You take a vulnerable brain, and let's just say the vulnerable brain is someone that has a predisposition um, to not being able to regulate their emotions, or they have and what is often referred to as an executive function deficit, which is often pinpointed with ADHD, with other types of anxiety disorders. Would you go so far as to say you take an individual who suffers from executive function deficits, then
yeah.
you combine that with some sort of arbitrary environmental occurrence, and that's where you kind of start this train moving?
Kind of. So there's
Okay.
lots of research on executive function deficits in OCD, and
Okay.
meta-analysis, which is like a summary of all the data that's out there, actually suggests that folks with OCD, they don't have an executive functioning deficit. But what they do tend to do is they tend to have learning histories where they've kind of learned that their thoughts are more significant than they really are. They've kind of become afraid of their intrusive thoughts and other sorts of internal private experiences. And they take them literally. So, I have daughters. I have two daughters. They're grown now. But when the oldest one was a baby, I remember very clearly, you give her a bottle. What do you do after you give a baby a bottle? You burp the baby. So you pat him on the back. And I remember one night in particular, I was sitting there, my wife's asleep, the baby's like 2 weeks old, give her a bottle, I start patting her on the back. And the thought goes through my mind, what's stopping you from rearing back and just beating the heck out of her, right? No one's here to stop me. I could do that, and that would not end well. That'd be
Right.
terrible. Now, me, I study OCD. I knew exactly what was happening. This is an intrusive thought. I know my thoughts aren't who I am. But we see lots of folks in the clinic who have that exact same experience, and they become terrified that they're a bad person, and they start avoiding the baby. And that starts to snowball. And so certain cognitive biases, ways of thinking that are not so much hardwired, but it's more the software. They've got a bug, they've got a virus in the way that they interpret and overestimate threat and responsibility. That seems to have something to do with, who then goes on and develops OCD, is what the research,
Yeah.
there are probably some biological factors as well. We don't really have a good understanding of what those are at that point. But there's, again, a mix of learning history, some biology, and then in some cases, an event that kind of sparks it off.
Yeah, that's interesting that you mentioned sort of the relationship between the individual and their thoughts,
Yeah,
and how that can contribute to these behaviors.
absolutely.
As I've gotten more into meditation, meditation is at least mindfulness meditation. A lot of the principles involve observing thoughts. One of my favorite quotes is, "You are not your thoughts."
Yeah,
And it's interesting to hear you say that that people with OCD may have this sort of tendency to overweigh the accuracy of their thoughts. I mean, we already know that negative self-talk is a big problem, right? Everyone's internal monologue is has this tendency to skew negative, and if we put too much weight into that, then it can lead to emotional disorders and things like that, right?
Yeah. Yeah, yeah, and you hit the nail on the head. People who take their thoughts at face value. If I have a thought about harming my baby, I look at the content of that. This means I'm a bad person. I'm dangerous. I could do this. I have to, avoid the baby because I'm dangerous, or confess the thought, or check to make sure it's not going to happen. Whereas most people, they just kind of learn, yeah, everyone has random thoughts. Geez, that would be terrible if I did that, but I'm not. That's not who I am. And so they're able to focus more on the process rather than the content. Oh yeah, this is me. I'm a person. I have all sorts of weird thoughts sometimes. This is just one of them, and that's okay. As opposed to, oh my goodness, this thought means something terrible because I'm thinking it.
Mm-hmm. Now, I am aware that people with OCD tend to use rationalizations to justify their compulsions. Um, but I'm curious as to what percentage of people with OCD are self-aware. A famous example, Howie Mandel suffers from OCD, and I've heard interviews with him, and it's very interesting. You hear him say, uh, he was doing an interview and someone was making an observation. They said, Howie, you don't shake anyone's hands because you're afraid of the germs, but I just saw you put a hand into a bucket of popcorn that was shared by everyone in this room, and that didn't bother you. And his reply was, you know, I'm crazy. It's not supposed to add up. And of course, he's exaggerating, with the crazy part. But the point he was making is that it didn't have internal consistency. His feelings weren't consistent.
Yeah.
To what extent are people with OCD aware of how rational or irrational their compulsions are?
Yeah, great question. And there's a spectrum of that. So
Okay.
most people, the vast majority of folks with OCD have insight. They do recognize, yeah, these thoughts, these fears, the anxiety that I have, that's not realistic. It's unrealistic. And then you've got kind of moving towards the other end. They're kind of like, well, it might be, but I don't want to take any chances. And then what research tells us is you've got about 4% of people who have OCD with poor insight, which means that they're not able to kind of understand that their obsessions and compulsions are unrealistic. They really strongly, almost to a delusional intensity, believe that this stuff is real.
Interesting.
Yeah.
Now, do OCD symptoms typically evolve over time? In the sense is it typical to see someone who has this pairing of obsession and compulsion? Let's just say it's a cleaning one, everything needs to be spotless, and then maybe certain stressors come up in someone's life, and then is it typical for them to develop new obsessions, new compulsions?
Yeah. Some people do. Some people like they have the contamination, type of OCD, and then they switch over, or they add, the checking and the responsibility for harm, or the taboo thoughts. But typically, what's more likely is that folks kind of stay within the general type of OCD that they have, but their obsessions, their fear triggers can kind of jump around. I'm afraid of doorknobs. Now I'm afraid of the bathroom. One of the, I guess, attributes of obsessions is that they're fairly specific, and they tend to kind of stick around over time. So we don't see as much shifts as we might think, or at least the theme doesn't shift all that much.
And okay, so that's surprising to me, given that that, you see, for example, well, if you take alcoholism, for example, I believe it's understood that alcoholism tends to be progressive, meaning it tends to get worse unless there's some outside acting factor. Um, and so if OCD symptoms don't tend to jump around, do they also fit that idea of untreated, will they just tend to get worse?
Over time, yeah. The symptoms will wax and wane. So sometimes higher, sometimes lower. And over time, things tend to deteriorate. It can get worse and worse.
I see.
The rate of spontaneously just kind of getting over the problem without any help is pretty low, unfortunately,
Okay.
for OCD.
I wanted to touch on some related conditions that may not fit the clinical diagnosis of OCD, or maybe they do. I'm not really sure. Um, Hoarders is a popular television show. I've enjoyed a few episodes of that. Could you talk about hoarding and how it relates to OCD?
Sure. So hoarding is a problem where people collect stuff and their home or their living space just gets all crowded, so much so that they can't function, or it's a fire hazard or stuff like that. And if you ever been in the home of someone who has hoarding, like whole rooms might be just filled with clutter and off limits. And the way you get down the hall is you have to walk, around all sorts of piles and piles of things. And it used to be thought that hoarding was a symptom of OCD. And I'm not sure how that happened, but in 2013, the American Psychiatric Association put out its latest version of that's called the Diagnostic and Statistical Manual of Mental Disorders. We call it the DSM. And they put out the 5th edition of that. And I think smartly, separated hoarding from OCD. There really isn't the same quality of obsessions and compulsions in hoarding that we see in real, bona fide OCD. So we think of hoarding as maybe a distant cousin of OCD. I personally don't even think of it as being in the same family as OCD. The
Wow.
treatments are different. Yeah, we now see that as a separate condition altogether. The
That
treatments are
surprises
different.
me.
A lot of the
Yeah.
kind of difficulties that people experience are very different.
That surprises me because as an outsider, it seems as though you look at watching the examples on hoarders, you see people that are obsessed with, they have obsessive thoughts that if they throw something away, it will eventually come back to haunt them. Uh, doing my elementary math, it's like, okay, then the compulsion is to hold on to that object.
So that I would say is OCD, right? So we can look at hoarding in from different perspectives, right? We can look at the clutter, and we can say, well, that person's got hoarding. What's more important is to look at the function of the hoarding and the saving behavior, right? So people with hoarding, they're going around, they're collecting stuff, and they're having trouble throwing it away. People with OCD can have obsessions. If I throw this away, then I'm going to need it at some point. And there can be some overlaps in terms of the way that those symptoms look. And of course, we can always find folks who have OCD and hoarding. That said, the treatments for the people who collect things actively, I'm collecting, versus the person that you described, who is, I'm afraid to throw this away. I have obsessional thoughts and I have to throw something away because it's going to come back to bite me in the future. You would treat those very, very differently. And those two kinds of people have very different, other sorts of psychological features.
Mm-hmm.
Yeah.
When you see the relationship between OCD and other anxiety disorders, other diagnoses, where, as you point out, the treatments might be completely different, the profiles might be completely different, but they're all kind of, there is something that unifies these, whether you want to call it anxiety or something else. When you look at how all of these types of diagnoses are interconnected, in terms of what it says about how our brain works? Maybe, does it scream any particular structures when you look at the 10,000-foot view
Structures, you mean?
that are contributing to, or structures or chemical pathways that might be related to all of these
Since
disorders?
the 1980s and 90s, the 1990s was the decade of the brain. So the National Institute of Mental Health said, 1990s, decade of the brain, we're going to figure out the biological basis, the brain neurological basis of all the psychiatric disorders. And we got nowhere. And we're still using antidepressants to treat like most of the problems like OCD and depression and eating disorders and things like that. And the truth is, even though we've spent billions of dollars, and I'm not exaggerating, on neuroimaging and genetics and this kind of brain research, we still don't understand very much about the biological kind of basis for OCD or really any of the mental disorders. We have maybe some guesses, but the studies are all over the place. We don't have a really good working model that we can say, oh, this person has, a problem with this part of the brain,
Right.
and that's why they have OCD. There's
Right.
no medical test for OCD. You can't take someone's blood. You can't do an image of their brain and say, oh, that's OCD and not depression or schizophrenia or no disorder at all. So I think that at this point in time, we can't say, here's the part of the brain that causes OCD. You need to have a brain to have OCD. So there's something going on in the brain, but probably that's just one piece of the puzzle. And we just don't understand how much that really contributes at this point.
So let's dive into treatments. Why don't we start by talking about historically, has there been a specific treatment program that we've learned doesn't work in terms of OCD? You mentioned sort of the perhaps overuse of antidepressants, but could you just talk about how we've gotten or how we've got to today when it comes to treating OCD?
Sure. So back in the like medieval times and until maybe 200 years ago, when people had OCD or really any mental disorder, of course they thought that they had evil spirits, and they would do things like let's bore holes in your head to let the evil spirits out, or let's have a religious seance or things like that. In the early part of the 20th century, so the 1900 to 1940s or so, psychoanalysis, Freudian psychoanalysis, was the treatment of choice. And OCD had a reputation for being a life sentence. If you had OCD, you weren't getting better, even if you spent thousands and thousands of dollars on psychoanalysis. It just didn't work. And in the 1950s and 60s, more scientifically oriented behavioral and cognitive behavioral psychologists looked at OCD and started to understand, this is not a problem with like Freudian, the id and the superego and things like this. This is a problem with thinking patterns, some of which we've talked about already, and behavior patterns. When I do a compulsive ritual, if I have a fear of germs and I go wash my hands, immediately that makes me feel better, right? I get the sense of relief. So I'm going to wash my hands again the next time I'm feeling germy. And when nothing happens, when I don't get sick, the washing is going to get the credit, right? So there's a mistaken cognition, and I've learned something through reinforcement. Wash to make yourself feel better, and that will keep you from getting sick. And so what the early behaviorists did was they said, we need to help people to learn that the situations they're afraid of and their intrusive thoughts aren't really dangerous. Well, how do we do that? Well, we have them confront these fears that are not really objectively dangerous and don't do the rituals and learn what happens afterwards. That's called exposure and response prevention.
Mhm.
When you do exposure and response prevention, or ERP, people learn. They learn new information. Oh, the doorknob isn't as dangerous as I thought. And even if I don't wash, I don't get sick, and my anxiety actually starts to go away, and I can manage that over time. And we still use those techniques that were developed in the 50s and 60s. We're still using them today with a great deal of success. They're not a panacea for everyone, but they're often very effective.
Hmm. I've heard a little bit about this uh, type of therapy, specifically how it might relate to phobias.
Yeah,
This graded response where you're slowly, gradually exposing someone to the stimulus. So if you're afraid of water in general, you start by having the patient think of a puddle and manage their anxiety, walk them through their anxiety. Then you work towards looking at a glass of water and, very gradually working up towards you're going to be in a swimming pool.
right.
Um, and it's very interesting, and it kind of passes the sniff test. Um, I am curious though, speaking of intrusive thoughts, um, you know, sometimes I used to live in a downtown area of Orlando, and you'd see lots of homeless people walking around, and you see some of them, they have their carts, the shopping carts full of all their belongings. And I see that, and it seems like these things signal some type of mental illness. And I have this intrusive thought, which is, I wonder if I were to walk over there and set that cart on fire. It's all of their belongings, right? That might be the best thing that ever happened to them, in the sense that it would it would force a fresh start, whether it's in a hospital, in a clinic, in a mental health facility. Basically an extreme version of exposure therapy. Now, obviously, it would be unethical to study something like that, right? To take somebody who's has a contamination type OCD and then, throw them into a pile of mud. But what are your thoughts on why does it have to be gradual? Is there any value into a more extreme approach to sort of shocking people into realizing that their behaviors might be irrational?
Yeah. I think, so when we do exposure and response prevention, we try to strike a balance between, going gradually enough that the person stays in therapy and is able to be successful and doesn't feel, too overwhelmed. But at the same time, that feeling of anxiety that they experience when they do exposure is gold, because we want the person to learn. Part of this is learning anxiety is not dangerous. I can manage anxiety. Just because I feel anxious doesn't mean that I'm really in danger. And so we want to strike this balance between, let's go gradually so that you're on board with doing this. At the same time, we got to push the envelope so that you can learn something new. We can't just take it so slowly that we're not getting anywhere. There's some patients that they say, bring it on, give me what you got, and that's great if they're willing to do that. So there's nothing inherently wrong with going for the most intense exposure right off the bat, because the worst thing that's going to happen is the person is going to feel anxious, and they're going to feel like they need to do their rituals. For most folks, though, we don't have to do that. There is research showing that you don't have to do that in order to be successful. Eventually, we want to get there, but it's usually, helpful to go at a more gradual pace,
Okay.
striking a balance so the person kind of learns to build on their successes.
Could you talk about perhaps one specific example of maybe a success story about that uses this exposure and response prevention?
Sure. Yeah. I've worked with people who, we can just go with a classic example, like contamination. So someone who was afraid of lots of things in their own home, right? So the kitchen counter, right? Because meat goes there sometimes, raw meat gets cut up and people touch it. And this person was afraid of trash cans, and they were afraid of doorknobs, and they were afraid primarily of the bathroom and the toilet and the sink in the bathroom and stuff like that. And what we did was we began with, we had them write down what are 10 to 15 situations that you avoid touching, or if you do touch them, you got to go and wash your hands, or even take a shower and change your clothes for this guy. And we put them in order. Let's start with the easiest ones. So the easiest ones was, touching the kitchen counter, getting, feeling contaminated, getting the contamination on your hands, not washing your hands, and let's go eat, some M&Ms or a Hershey Kiss or some sort of, finger food, and not wash and see. This person predicted, I'm going to get sick if I do that. You got to be kidding me. Well, he was able to give it a shot, and a couple of weeks went by of doing, this kind of thing, touching the kitchen counter, then touching some doorknobs. He never got sick. And he learned, maybe I was wrong about this. Maybe I was overestimating the risk. And so then he was like, you know what? I think I'm ready to try, more stuff. So let's go in the bathroom. So we were doing this over Zoom. It was during the pandemic. And so, he brought his laptop into the bathroom, and there were different bathrooms in his house, and some of them were easier than others. We started with an easier bathroom. Let's touch the toilet, the flusher, right? Let's touch the seat, right? And then let's go eat, right? Let's, because people do that sometimes. Most people do wash their hands, and there's nothing wrong with washing your hands after you use the bathroom, but that's not going to make the difference between getting sick and not getting sick. And this fella had to learn that. So we would touch the, toilet and touch the flusher, go and eat. Lo and behold, still didn't get sick, working up to more and more difficult bathrooms. And over time, he learned, I don't have to wash my hands so much because it doesn't really, keep me from getting sick, because I wasn't going to get sick anyway. Now, I should say, Ryan, that's a very, very straightforward. That was like one of the most straightforward people that I ever treated. It usually doesn't go that smoothly, but that's the idea. And in many cases, it does go that smoothly. But that's kind of what we're looking at. And as a therapist, my job is to coach the person through it, give them lots of support. You can do this. I know it's hard. I know how, uncomfortable this is. And this is great. You're learning from this. You're strong. I believe in you. That's the idea of the therapist, of what we do during exposure.
Now, is there, I'm interested in a little bit more about this. Is there a secret sauce to the process? And what I mean by that is, I could, you could have a friend walk you through this process too, theoretically. What are you anxious about? Well, you could even send them an article that explains why, the likelihood that you're going to get sick from touching a counter. But that doesn't strike me as effective. Yeah. What in your experience leads to this that increases the likelihood of this type of treatment working?
Yeah. Well, so first of all, let me say that you can't talk someone out of OCD. In fact, trying to do that only makes things worse. That using logic, trying to use logic, is kind of like a compulsive ritual. It's like the person trying to reassure themselves. And so we don't do that kind of, let me explain to you the 10 reasons why you shouldn't be afraid of the toilet seat. That doesn't work. And the person usually has come across that information first. They know that. They need to learn from experience. Experience is the best teacher. And that's why exposure and response prevention is really the first line treatment for OCD. That's the one that, we have the best research on, showing how successful it is. There's the science, which is when you confront your fear and the fear is irrational and nothing happens, you learn not to be afraid. We've all overcome fears. Most of us have overcome fears, that way, whether it's the high dive or the dark or, whatever. But there's also the art of the therapy. How does the therapist work with the patient or client to help them to engage in the exposures? How does the therapist set up the correct types of exposures, which can be really complicated depending on the type of OCD symptoms that the person has. So there is, you got to be working with someone who has experience, expertise. How do you help someone who's in that moment where they're feeling really anxious? Do you just kind of give in and say, oh, you're really anxious, go wash your hands, versus supporting them? You can get through this. And so, folks who know how to do this therapy, they've had specific types of training. And if you're listening and you have OCD and you're looking for this therapy, you want to find someone who has lots of experience doing exposure and response prevention. It's not just any therapist, around the block.
Well, thank you so much. I think we'll end it there. It's been a pleasure. I felt like got a fire hose of information, but all super interesting and insightful. Thank you so much for being on, John Abramowitz.
Thanks for having me, Ryan. It's been my pleasure.
For more on John, visit his website at jabramowitz.com. That's jabramowitz.com. Or visit iocdf.org to learn more about OCD. You can also pick up a copy of the second edition of John's book, Getting Over OCD, a 10-step workbook for taking back your life. If you enjoy this podcast, please share an episode with 2 of your friends. Head over to Patreon to become a paid supporter of the show. You'll gain early access to episodes, as well as bonus video content. Follow on Instagram or Facebook at Why Do We Do That Podcast, or Twitter at WDWDTPod. As always, feel free to email me with comments or guest suggestions at whydowedothatpodcast@gmail.com. Until next time, this is Dr. Ryan Moyer, hoping you found some answers to the question, why do we do that?